So I'm really excited to be here to see all of you guys today. This is a super exciting time to be in the field of neuroscience. There's so many new treatments and new therapies that are coming out every day on things from MS to Parkinson's, new advancements in stroke. So this is a really exciting time for you to be involved, and I hope that the talk that I give today will help to inspire you and make you see that even for, if I can do it, then you can absolutely have a wonderful career in science as well. So the flow of the talk will be first discussing kind of what I'm currently working on now, and then I'm going to go through how I navigated through my career path, and then we'll talk about how you might be able to set your own career path looking at some of the things that I went through. So right now I'm at the University of Florida. They built a brand new hospital specifically just for neurologic patients and cardiovascular patients. The University of Florida is in Gainesville, so right kind of like in the center of central Florida. There are 3 hospitals that are on the main campus of University of Florida, so actually a lot of patients come, from even South Georgia all the way to Tallahassee. Occasionally you get some patients from Palm Beach area. A lot of patients from Jacksonville. You get patients from Tallahassee. There's 192 beds in the Cancer Center, which is one of the newer hospitals. Then there's 683 beds in the General Hospital, which has most of the internal medicine patients and the surgery patients. And the neuromedicine cardiac hospital that was just built has 216 beds in it. The neuro ICU has about 40 beds in it total, or 48. I think it's 24, a dual wing, 24 on each side. On our clinical team, we have usually 1 attending that will be on service. You have lots of medical students, you have fellows, nurse practitioners. Everybody is working together, coordinated to see the patients who are in the hospital, either on the stroke service or neurology service, or on another service in the hospital, in addition to responding to patients who are in the emergency room. One of the unique things about Florida is that even though it's a slender state, there's a lot of rural areas in the northern part of Florida. So there are patients at times who will be helicoptered in close proximity from their home directly to our emergency room and not even go to like a local ER as a drip and ship model. So you will see a variety of patients, variety of pathology there, and you're able to really help patients who are in that region. Even I've seen patients who are from Valdosta, Georgia, who will drive 2 or 3 hours away just to come to a clinic appointment to see you, to follow up on their stroke. So getting to stroke, that's basically what I do. I'm a stroke neurologist. I see patients who have problems with the blood vessels in the brain, either that being an abnormal tangle of vessels or a problem in the way that the vessels developed. Either they may have had a stroke, so they could have hemorrhaged into the brain, or most frequently they've had an ischemic stroke, which I've given you a picture of here that kind of explains what happens with that. There are blood vessels that wrap around the base of the brain and all the way along the side so that we can get blood flow to all of the tissue. And when a clot or a tear or something happens in the blood vessel that blocks off the flow, it's just like getting a problem in your sprinkler system. If you cut off a piece of the flow from your grass, then that lawn will die, and the same thing happens with your brain. So if you don't have enough blood flow going to a specific area in the brain because the blood vessel is blocked off, then those neurons die, and they die very quickly. So the brain is very metabolically active. It needs oxygen, it needs glucose so that the tissue can survive. And if you're not getting blood there, which is the carrier for all of those things, then the cells die pretty quickly, which can be a big problem for the patients, as you can imagine. There's things that can contribute to this, a wide variety of pathology, which we investigate when the patients are in the hospital so that we can try to prevent them from having another stroke again. We will also look and define how much damage has been done by the stroke, and then try to get them to a rehabilitation center so that they can try to get back as much meaningful activity of their lives. But at the end of the day, it's still one of the leading causes of death and one of the leading causes of disability in the U.S. So a significant cost burden for healthcare resources, in addition to taking patients away from being able to do the things that we all take for granted. Something as simple as being able to walk, to drive, or even work, even when their deficits aren't as severe as some patients would have. If you can't notice it across the room because they're weak in one arm or one leg, the patient may still have some cognitive deficits that affects their ability to do something that they were able to do easily before, like being an accountant. Someone who helps people with their taxes, answering phone calls for people. It can be quite disabling, and when you disrupt that quality of life for one person, it trickles down to the rest of the community. So it's a problem for everyone when we have patients who end up with, having significant disability. So we try to treat patients who have stroke. If you have a blockage there, then the idea would be well, why don't you get rid of the blockage? And we do try to do that. We have a medication that we can give to kind of bust up the clot. But in doing that, potentially we can cause more problems that can be devastating for the patient. That's what we call hemorrhagic transformation. This is a CT scan here, which shows the white areas are blood within the brain tissue. So the clot-busting medication did break up the clot, but the person is still left with some damage. You can see that dark area on the CT scan, and they've now bled into tissue that was otherwise not damaged. So we try to advance the way that we practice clinically so we can try to prevent those things, We can get MRI scans, and we can try to isolate exactly the perfect mismatch. So meaning, let's say you've got a plant and you forgot to water the plant, but you caught it right as the leaves were starting to limp over. You can re-water the plant, and maybe the plant will bounce back, and you've not killed the entire plant. You've been able to restore everything. And that's kind of sort of what we try to do with patients who come in who may have a lot of tissue at risk. This is a perfusion scan, which shows that there's a delay in flow here, but there's a core infarct volume here on the diffusion weighted sequence in the ADC. If we can remove this perfusion deficit, that we could save all the rest of this tissue that isn't damaged and improve the quality of life for that patient. So we go to try to make sure we can identify any blockages that we see, remove the blockage that's present. We take some very aggressive approaches at even taking a patient down to an angio suite so we can identify the blockage here. So here's normal, so you see all of those blood vessels that you normally would see, and here they're missing. And even in doing that, with some of the most advanced care that we have, going in with a catheter, which you can see here being deployed and pulling out the clot, we still can end up with residual deficits. So having the blood flow restored, you can still have hemorrhagic transformation within the bed of the stroke, and sometimes you can even have stroke progression. So that's where a lot of research questions come about, and the same sort of research questions that I have. Again, going back what Dr. Knopf was saying, when you are looking at the patients and you see what is bothering them the most, it gives you an advantage of knowing what's clinically relevant to the patient. What are the real true problems that we need to solve? And one of the difficulties is that we're not able to tease out exactly the best way of defining how to treat patients safely without causing any harm and being able to save as many people as possible. There's imaging modalities that would help with teasing out what's the best profile by looking at the mismatch like I showed you there, which can be helpful. But is that always true? Is that always the case? So this is an example of a patient that I saw while I was a fellow. Again, going back to the take-home point here is that you see the patient in the emergency room, you get the experience of finding out what bothers them the most and come up with the clinical questions. So this patient was getting ready for a trip. He was packing up with his wife, and this was like early in the morning, right before their flight, and the wife went to the bathroom to do something and came back and found the patient have weakness on the right side of his body, and he wasn't acting like himself. So she called 911 and got him to the emergency room. When he got into the emergency room, we do an NIH stroke scale, which is a scale that allows you to determine how severely affected someone is from their stroke. And it was 23, which is a very big number. So that's a pretty severely affected patient. When I saw the patient, we evaluated him, we got his MRI scan. I saw that he was able to get acute therapy to bust up the clot with TPA. I gave him the TPA, and then quickly the patient actually started to get better. It's one of those really great cases which you actually get to see right before your eyes, a person who literally could not even have a flicker of movement in his arm or leg, and all of a sudden he's starting to move, he's starting to be able to attend to his world and know what's going on. And then the next day when I go to see him, he has just a little tiny minor facial droop, but aside from that, no other clinical deficits at all. So that's a pretty amazing outcome, We're able to evaluate him almost within 2 hours of his symptom onset. We're able to give him TPA really quickly, and we were able to achieve reperfusion. And in this case, we were able to do that without even, going for recanalization. So these are the MRI images of this patient here. So this is the diffusion-weighted sequence, which I showed you an example of before, and the abnormality is the white area. So you can see his infarct. He had a nice size infarct. Here's the diffusion-weighted sequence, and then the ADC is on the bottom where the infarct is black. When we rescanned him using the NIH Research Natural History Protocol, right after the patient recanalized and reperfused, we saw that it looked like we were all high-fiving each other and said, we completely, prevented this person from having a full-blown on stroke. So this is, awesome. This is fantastic. He's doing great. And then the next day we get the scan and we think that the MRI is going to be completely clean, and it wasn't. He still had some infarct there on the right frontal lobe, but he was otherwise pretty asymptomatic other than that very mild facial droop, which is very interesting. So the other question that we had is then if you really can reverse infarcts or the actual damage that you see that's going on that you think is something that's permanent, can you actually also reverse some of the ongoing processes that lead to breakdown of the blood-brain barrier and risk of the hemorrhaging that I was telling you about, which is so problematic? Now take that and compare it to a different patient that I was involved in the care of. This patient had very similar comorbidities to the person that's on the bottom. So this patient, the one that's on the top here, came in the same way, was given TPA. He did not recanalize, and he had significant baseline comorbidities as far as his congestive heart failure. So he was not a candidate for an endovascular technique to go and retrieve the clot. But what you see is that he had tissue at risk, just like this gentleman did, but his infarct progressed and stayed quite evident and even grew at 24 hours, whereas this patient's reduced acutely and then even is a little bit smaller at 24 hours than it was initially. So these early changes in the infarct volume became very curious to me. It's like, is this really relevant? Does this really give us a biomarker for how a patient might do after you give them therapy? And could this be used to tease out who is likely going to do well or who may not do well? And then if we can determine that early on, maybe we can also connect that with what's going on in the body and figure out why these two patients may respond differently. So the bedside back to the bench questions were, can we better define what our clinically relevant imaging biomarkers are, and then can we use that to come up with new therapeutic targets? Because patients who do have disability after stroke can, again, like I was saying, have a decrease in their quality of life, and that affects them and also their community that they live in. So this would provide a unique ability to do translational research, kind of like in a different way, which normally we would go from the bench and then try to translate that to humans, but instead we're talking about going in the other direction. So take what we see, what's going on in patients, and use that to tailor our bench questions. So the first thing that I did was to look at the infarct volumes in a registry where we measure the size of the infarcts and see how they're changing over time, and then match that with how patients were doing clinically. And this gives some examples of the patients that have different kinds of changes in infarct volume while they are initially presenting, after they've been given therapy, and then at 24 hours. And what we were able to find is that these early changes that happen at this time point are actually quite important for predicting how well patients will do from acute thrombolysis. And that's even if you adjust for the NI stroke scale or how severely affected the patient might be. So that's the bottom part of the graph there. So the next question was then to see if we could determine if that's going to also correlate with protection from hemorrhagic transformation. So that little thin layer that helps to keep blood from interfacing with the neurons. And to do that, I worked with Dr. Lee, who had a pipeline program where he created a way to use the perfusion scans to calculate blood-brain barrier disruption, or leakage of gadolinium across the blood-brain barrier into the tissue, and very small amounts of blood-brain barrier disruption, and then also be able to quantitate that so you can determine if someone has a lot or a little and where the actual location is relative to the stroke. And for the patient that I presented, the first one, you can see that initially he had a lot of blood-brain barrier disruption. That's the first scan all the way to your far right. And then at 2 hours, some of that blood-brain barrier disruption resolves, but some comes back at 24 hours, but not nearly as severe as it was at baseline. This completely changes the way that we think about blood-brain barrier disruption and hemorrhagic transformation and what we can actually do to treat patients. So we took all of the patients that we had imaging on and did the automated calculations and found that you do have some patients who will have increase in permeability over time, and that was the traditional dogma or thought, but then you do have patients who actually will have some reversal of that. And the amount of reversal that occurs correlates with early reperfusion. Taking that a step further, if we looked at the areas that are highly concentrated with lots of blood-brain barrier disruption, we were able to identify a correlation with the patients who actually were the ones who had the hemorrhagic transformation from their stroke. So that changes the way we think about what we could do for patients. So there's blood-brain barrier disruption, yes. Some of that may be reversible, so that means that there's some components of the blood-brain barrier that are still maybe modifiable by a therapeutic agent. And then if you're able to take harness of that, then maybe potentially you could even prevent this focal high-intensity blood-brain barrier disruption from happening. And this is how we would be able to use the unique translational ideas of going from bench to bedside. So how are we going to do that? So we have the imaging. We've got to find something else in addition to the imaging to be able to test at the bedside. And that would be potentially with actually taking samples from patients during the time when they're getting these MRI scans. And there are ways that you could look at the genomic changes that are happening, the messenger RNA, the microRNA, the things that will then go on to develop and change the modulation in your pathways and protein production during the time when a person is having an acute stroke. There are several other people who have looked at microRNA analysis in acute stroke patients, but not really during the hyperacute phases. So they were mainly getting blood samples from patients, and then they would say yes or no, they've had a stroke on their admission, and maybe get some blood the follow-up day, in the morning. But that's helpful, but again, that wouldn't help the patients that I've, saw and that came and presented to see me in the emergency room. So that brings the way that you would change your approach and get blood samples acutely and then correspond those changes to the actual changes that you'd have in your MRI sequences. And that would take the murky picture that you have and you could clear up that picture and give you a better sense of the different fingerprints or different profiles that are happening in patients when they've had an acute stroke, and then help you to guide how you would go from the clinic side back to the bench. And the way that the NIH Stroke Division is doing that with a natural history of stroke blood pilot study. So patients had blood samples that were collected. So when they come into the emergency room, just like that patient that I showed you, they would get blood drawn, and they would have clinical outcome measures because we have to figure out if there's something that's actually going to change outcomes from the patient. And then we would select patients that would be best included in a study where we're looking for changes in your white blood cell profile, so excluding people who might have changes for other reasons, like they had surgery or they had some sort of infection, and then make sure that they fit the appropriate inclusion criteria for adult patients who could get MRI scans. Putting this kind of a project together took a lot of work and effort from the staff members at the NINDS stroke branch, and a lot of this work was done before I came in as a fellow, where they developed a protocol to obtain the blood samples so that this kind of project could be done. The key thing is that we have to make sure that you're not changing or interfering with this quick flow that has to happen when you're treating an acute patient. So there was a lot of thought process that went into making sure that the workflow still flowed and that patients still were able to meet their door-to-needle metrics and get enrolled into the study. And so one of the first patients that got enrolled, I enrolled at Suburban Hospital into the blood collection component of the natural history study. So the patients would come into the ER, they present with their symptoms, they get a blood sample drawn under a temporary waiver of consent. You then do what you need to do to treat the patient, and then if the patient consents, then the blood sample is kept, and then you continue to collect your follow-up blood samples on the patients. And so far, the things that I've been looking at are changes in how people respond neurologically and also changes in the MRI phenotypes. And here's an example of one of the PCA graphs from that particular study. So now I'll switch gears and then we'll talk about things that would show you that I'm really no different from any of you bright students that are here in the auditorium today. So my career path started basically when I was in grade school, and I had a lot of people in my family that had, medical problems, stroke and cerebral palsy and epilepsy. So medical illness was something that was always around me, or in, things that we talked about at home. But one of the things that really triggered my interest is when I was in 5th grade, we had a part of our science book that showed lung samples, and one of the pictures showed how a person's lungs would change in their morphology after a person smoked for many years. And I thought that that was the wildest thing ever, that you could actually, your lung would literally turn black. Like, what is all this stuff in this person's lung? This is horrible. Why would anybody want to have this to happen to them? And I went, after that year of school, I went to my family reunion with my family, and I saw one of my, great aunts was smoking a cigarette. And I harped on her so much, so long, that she finally quit. I just went on and on and on about the black lung, that she's like, if she's talking this much and this mubby, this is a bad thing. And maybe I shouldn't really do this. And to this day, she, does not smoke at all. And I, from that experience, took the ability, understanding the power that you could have to actually make things better for another person, just by educating someone on the things that they can do to better their health. And from then, I was kind of hooked to the idea of science and medicine. So when I wanted to decide where to go to high school, I could have gone to the high school that was right around the corner from me, or like within my district, but there was a magnet school that was also available in Augusta, where I grew up, and it was called A.R. Johnson, and it's a magnet health science school. So they had one component was geared for people who wanted to have some exposure to medicine, and then there was another half of the school that was geared to people who wanted to have exposure to engineering. So I chose the clinical side of things, and we learned all kinds of things about nursing care. I learned how to tuck those corners in, making the beds. We learned how to check blood pressures. They really made us go through the full gamut of care of learning how to be basically like a nurse assistant while you were in high school. We had clinical rotations. We had to wear a uniform to each of our rotations, which we used to call like a banana suit. It was like a yellow top, and pastel yellow pants that we had to wear to all of our rotations. We had to wear the whole like white sneakers, no scuff marks, no fingernail polish. It was a very, very, they wanted us to make sure that we appeared to our places where we were going to do our rotations in a professional manner, and then we took the position very seriously. And I learned quite a bit about medicine and interacting with patients from that experience. And then during one of my last years while I was there, I took a chemistry course. And that was part of our regular routine, part of our curriculum. But lucky for me, the chemistry teacher that we had was someone that was retiring and moved from another district and came and decided that she was going to teach the chemistry course for us at A.R. Johnson. And she just made chemistry so fun and so easy to understand that I just gravitated towards chemistry and lab work. I mean, you had to practically just not come to class to not get it. That's how wonderful and effective a teacher she was. As I finished my high school training, I decided that I had the opportunity to go to the local community college at night and take some extra courses. And I have older siblings. I had brothers, 3 older brothers, and I saw my older brothers going to school, taking college courses. And I was like, doesn't seem like it's too tough on them. Why not? If the opportunity is there, I'll go ahead and expose myself to that. So I took some courses at night and on like some basic like algebra type things like that. And I felt like that was a very, very good and interesting experience. For one, it was night school, so most of the people in community college, so most of the people that were there were maybe 10 or 15 years older than me. And I'm sitting there in this class with all these other people who have kids or talking about picking up people from daycare and things like that, and their acute awareness of how important their time was and how important it was that they learn what they needed to get out of that course. Because the students who are in this kind of setting, they were basically paying out of pocket, and the hardship of paying for school was a very real thing, which is not something that you necessarily always get if you are, if you're going to school, but you're going to school with other people who are in their same age frame and they're not working all during the day and have to do the same sort of cook for their kids and things like that at night, and then also pay tuition and maybe pay out of pocket and not even have, be able to get student loans to help to pay them through school. And that I felt like was a good wake-up call on how important it was to focus your time and make sure that you get what you need out of the experience. So after high school, I decided on staying in Augusta to go to that community college. I thought about the different opportunities and things that were available, and I decided to stay there partly because there was a Hope Scholarship in Georgia, so if you kept your GPA up to a certain point, they would pay for some of your tuition, and my parents told me that they would do anything that they could to support me by allowing me to stay at home if I wanted to. And the rest of the tuition and things like that would be on me, but they would, be in support of everything else that I wanted to do. And so I said, that, to me, this works out as a great deal. I'll have my tuition covered, and I don't mind. As long as I work hard, I'll stay right here at this community college and give it my all, and I think that I'll still be successful even if I don't go to the top Ivy League school in the U.S. So that's what I did. And I met wonderful mentors there while I was at Augusta. It started off as Augusta College and changed names multiple times. Now it's Augusta Regents, which includes both the medical college and what was a community college before and is now like a big university campus. And one of the people that mentored me was my organic chemistry teacher. And he told me about a program which is very similar to what you're doing now. That was at the Medical College of Georgia, and they called it SEEP or REAP at that time. And it was a way for students who are either high school or pre-medicine to come into a lab and learn about research and learn about science and impacting patients' care. And that completely glued me to wanting to stick with science and work on something that would affect patients and also advance care for them. I had never really thought about science, didn't really know much about where all the drugs and medications and things like that came from. I assumed it just came, that yes, they come from the pharmacy, but the actual backstory about how you get there was all exposed to me by participating in this program. And I worked on some projects there and got some awards, and then decided on going to college and was accepted into the MD.PhD, medical school is accepted into the MD.PhD program there at the Medical College of Georgia. And this is Dr. Fagan. So I'm looking in the microscope, there's Dr. Fagan there. And I worked in her lab. She worked in the Department of Pharmacology at University of Georgia, and they had an actual on-site suite within the Medical College of Georgia and did a lot of collaborative research on stroke. Initially, I thought that I was going to work on things that were related to pediatrics. And so I put on my form that I wanted to work with pediatrics and maybe sickle cell. And I think that they looked at the form and said, well, we don't have anyone doing that, but patients who have sickle cell have stroke. So we'll have her work with Dr. Fagan. And that's how I got connected with her. So while I was in medical school, I had the MD.PhD program that helped to supplement my tuition, along with a Stony Brook scholarship that helped to cover costs for tuition, and then got some additional stipend money to help with cost of living and paying for books and things like that. I had a lot of wonderful mentors during my graduate school. I did some preclinical research on a drug therapy, soluble epoxide hydrolase inhibitors, which were a new drug molecule that was being used to try to see if it could actually decrease stroke size volumes in an animal model of stroke. And I did that work with Dr. John Emick in his lab, and actually was able to get NIH funding to help to support my time as a graduate student. That work ultimately ended up being presented at the experimental biology meeting, and then also I was able to do a platform talk at the International Stroke Conference, which was quite amazing, and was able to go back into the clinical setting after I finished my graduate studies, and really, really enjoyed my time with neurology, just love learning about the brain. And so I next had to decide what I was going to do with all this information that I had learned about vascular remodeling and also microarray analysis, so messenger RNA changes that happen in animals or in their brain after they've had an acute stroke, and how I could take that and continue to work on those things. So the next question becomes, okay, now it's time to leave medical school and you need to find a residency program to go to. And so this is the match day at the Medical College of Georgia, and the gentleman on the side there is a reporter from the newspaper in Augusta who is doing a story on match day, and to my surprise, my letter said that I was accepted to Johns Hopkins. And so the picture is a little bit shaky, it's a little bit blurry because both myself and my mom were so excited she couldn't keep the camera straight when she was taking the picture. So off to Johns Hopkins I went, leaving the nice, warm, hot, humid Augusta and coming up to Baltimore, where you get to see nice, pretty snow, and enjoyed my time during the neurology residency. It was a rigorous training program. They really make sure that you learn what you need to learn to practice neurology and help patients, and then was able to do the R25, which is also help with funding through the NIH, and worked on the project that Dr. Lee alluded to, which is looking at inflammation in a preclinical model of cerebral ischemia. So at this point I decided, okay, well, I've learned a lot about animal models. What about taking it a step further and going a little bit lower resolution and looking specifically at cell structure and inflammation? One of the projects that I left or ended off with my graduate studies was actually looking at infiltration of immune cells into the bed of the stroke. And so I thought this was a nice way to caveat off of that. So now I am at the point where, again, to recap you, that's 4.5 years of college, 8 years of medical school and graduate school training, 1 year of internal medicine, internship, and then 3 years of neurology residency. So that's about 16 years of training. And so the next thing you have to decide is then, okay, well, do I have what I need to do the career that I want? You know, when I graduated my medical school, this picture over here on the side, this is my dad down here. My mom is in the back there. This is my godfather, who is an internal medicine physician. And my dad had had a stroke not too long prior to this. And so the answer to that question for me was no. I'm not any closer to really changing the direction and management of patients who have had stroke. So the next step was to do a vascular neurology fellowship. So this is the MRI suite at Suburban Hospital. These are some of the fellows from the second year of my neurology fellowship. This Amjad and Tina, Nidhi, and Saeed. And I had a really great experience, learned so much about stroke and doing clinical research and translational clinical research during that time. And due to all of the wonderful mentorship that I had, I was fairly productive and was able to do a lot of things on the NIH campus, staying involved with the NIH communities and fellow committees, and was able to help with the Distinguished Clinical Teaching Award, which was great, and then capping off the year with winning the Innovative Science Award from the Stroke Journal at the International Stroke Conference for the blood-brain barrier disruption project that we showed the first time in humans that the blood-brain barrier disruption can be reversible in ischemic stroke. And in addition to that, some of the other things that I learned and branched out in my time during my fellowship was actually going back again to community outreach. Because like I said, patients who've had stroke, it affects everyone. It affects the whole community when you have someone who's taken all of the things that they're able to do in life are taken away from them. So I helped with doing some talks at a jazz brunch that was put together by Dr. Johnson, who's at Johns Hopkins, who puts together these community events for people to come learn about cerebrovascular disease and be screened and checked almost like a health fair to see if their blood pressure is high, what can they do to prevent themselves from having another stroke. And then also did a couple of phone banks with the ABC News to answer phone calls from patients, people who just happen to be sitting watching the news and would see us on the intermittently in between stories, that we were there to answer questions, and they could call us and ask anything that they wanted to ask, the things that they were afraid to ask their primary care physicians about how to prevent their chances of having stroke. And you'd be amazed at some of the questions that they would ask. These are really relevant and important questions, questions about their medications, questions about their diet, things that are really key and important to make sure that they are sticking with to make sure that they don't have a stroke. And doing those kinds of things just disseminates all of the information out to everyone. So not just the people who are sitting with you who come to the emergency room, but anyone before they've actually had the event, which is even better than just trying to treat when the person actually has had a stroke. Right now, I'm an assistant professor of neurology at University of Florida, but I'm also participating in the Transcends AN program, which is a wonderful mentorship program that's headed and being funded through AN to help young faculty members to attain research funding and support, and also helps us to learn how to contribute to science with leadership skills and mentoring down to other people who are coming up through the program. So that's my career path, or the simplified version of my career path. So what's your career path? How are you going to get to where you want to be? What is it that you actually want to do? These are the things that you need to start to think about. And sometimes you may not have the answers all at once, but more than just knowing kind of sort of my story and how I got to where I'm at now as an assistant professor, I would like for you to be able to take home at least some sets of questions to help you to put together a development plan for yourself, an individual development plan for yourself so that you can have something to help you navigate your success through your career, because everyone is very individual. You all have your own specific strengths, something that makes you perfectly you, a skill that you have that no one else has. And you have to be able to take that and harness it and listen to yourself, be true to yourself about what it is that makes you wake up in the morning and be excited about science, excited about neuroscience, excited about contributing to making things better for others. And in doing that, you want to make sure that you expose yourself to as many different opportunities or career jobs as possible. All of the things that I learned about and did, going through meeting, all of these wonderful mentors, getting myself to the point where I was even doing a research project, that was from exposure. I did not know about these potential career opportunities until Dr. Strobel took the flyer off the wall and said, here, you need to apply for this. So it's all about making sure that you have a good team or good mentors to help you, to guide you, and don't be afraid to look out there and adventure for any other career opportunities that happen to come your path. The neuroscience is a huge avenue of different ways of being able to contribute. And there's so many different diseases there that need someone to help to come up with the new treatment or drug or therapy, or even the basic science fundamental understanding of how something works. There's so many questions to be answered that you would definitely be able to stick with your things that you're passionate about, and you will definitely be successful. But it's always important to make sure that you're staying true to yourself and picking something that helps to make you wake up in the morning and say, this is still on my mind, this burning question, I don't understand why this has to be this way, there has to be a better way of doing something. That thing that you can't really get around, that you're always thinking about, that's your passion. And then you take the things that you have, your strengths, your skills, and you hone those so that you could get at answering that question. And then make sure that you're exposed to the different career opportunities like you're doing now with this program, so that you don't miss out on any kind of opportunity that would help to get you to the direction that you want to go. So for me, the things that helped me to kind of keep my focus and the passion on what I was doing all was pertaining to my exposure to patients who've had stroke, my family members, being exposed to the different people who helped to advance my career and teaching me different things about neuroscience and the love of understanding what's going on for the brain. But you have to figure out what's individual to you. The next question that you want to ask yourself, once you've figured out kind of sort of what you want to do, and you may not know exactly now, and that's okay, is how you're going to reach that goal. You have to have some sort of sense of direction on how you're going to navigate through things. You need to plan and prepare, and you have to be focused. When you're focused on your specific goal of what you want to decide on, that allows you to make very clear decisions that help you to get to exactly the direction that you're wanting to go on. If you have a highly focused, targeted question and you're lasered in on that, you're less likely to deviate off to other things and be distracted by other things that are going on. But always be, willing to be open and reevaluate things over time. So it doesn't mean that you have to stick specifically with one plan and that's the only direction that you'll go in. Things kind of will change as you grow and as you're exposed to different things. And again, going back to myself, I did not think that I was going to apply to neurology, adult neurology. When I was going to A.R. Johnson, I thought that I was going to be a pediatrician. And until I actually did my rotations, and I was all about the well baby checks. Those were great. But then when I saw the patients who were really, really sick in the pediatric ICU, it's like, well, I'm not sure if this would really be for me in the long run, but that's something that's specific for me. And I was willing to change and adapt based off of what I felt like actually was really something that drove my interest. And so sometimes you'll need to adapt your approach as well as time goes on. The next thing that you want to ask yourself, once you've figured out kind of sort of what you want to do and you think you have a plan, is do you have the resources to actually implement that plan? Who are your mentors? Who are you reaching out to help? Who is your Verizon network? And are you seeking out information on your own to help you to navigate through things? And then the next thing that you want to ask is if the training plan that you have set for yourself is really going to get you where you want to be. Really, in doing this kind of career choice, you have the ability to create your own career development plan and make sure that you're exposed to different opportunities that are going to help to get you to the place where you want to be. You would pick the lab that you want to do your postdoc in. You would pick the residency program that you want to go to. As you are navigating through things, you would pick the mentor that you want to work with who's doing a specific research project that has an interest to you. But you'd have to kind of build up your toolbox or build up your skill set in order to be able to act on those things. And no one can do any of these things alone. So I put all of these pictures up here, not just to show my face over and over, but the pictures that you see always had myself, but I wasn't really in those pictures by myself. I was in those pictures with other people, a network of people who helped me, as the mentors were and the community that helped to shuttle me through all of the pitfalls were just as important as me being able to navigate and change my approach and adapt to any kind of things that would be somewhat perceived as potentially a setback. So you want to make sure you're building a good network. And part of doing that is being a good mentee and making sure that you're come with a set plan of what you need and where your mentor may be able to help you best. The last point, or the last question that you want to ask yourself is, what about when I have a setback? And how do I have a work-life balance that's going to work for me? Well, that's one of these things that comes with, navigating through life. There'll be situations where you think that something was the optimal way of doing something and it didn't work out. But you have to look, it's all about your approach and how you take that situation and respond to it, more important than it is the perceived setback. So for me, when I did this research project here, the one that got me all of the accolades, the awards, all that string of awards that I got from all that work, those were not initially positive results. The first time when I analyzed the data, I was like, this is not right. It's this negative. It didn't work out the way that I thought it was going to. And I had to actually sit and think for a while and figure out what that meant and how to interpret it so that I could go on to the next question or the next test that I was going to use to confirm my now new hypothesis. And that first negative or setback result is what actually propelled me to get all these other positive findings and actually be able to publish publications that have been cited multiple times and continue to be cited today. And the next thing that you want to do is make sure you're enjoying what you do. Pick something that you enjoy. That's going to help you to be resilient regardless of what kind of perceived setbacks that you might have, or if something doesn't work out exactly the way that you thought it was supposed to. When you're enjoying what you do, you can refocus and reapproach whatever situation that comes up and then just keep going at it. There are going to be times where things may not work out perfectly the way that you thought that they were going to, but these are times where you're being shaped. I truly feel like everything that you're exposed to in life is to hone you and make you better and learn from the situation so that you can actually be better to either know what to do better the next time or help someone who's coming up behind you not make the same mistakes that you made. And don't forget to enjoy your job. That's the key thing, is making sure you're enjoying what you're doing, making sure that you're staying true to yourself, that you're doing something that really gives a burn in your belly, that you give yourself a set plan, you connect yourself with good mentors, and you be a good mentee, and you will be able to navigate through all of these things, no matter what happens to come along your way. So I have to thank all of the people who helped me. I don't have even all of the people that I would consider to be my Verizon network or my team of mentors who've helped me throughout the years. Definitely, you have to thank Dr. Latour, who helped me to be able to participate in this research in the first place, and also Dr. Lee. And would be remiss if I didn't thank my UF team who's covering for me while I'm away so that I could come and give this talk to you guys today. So I thank you for all of your attention. I hope that that was helpful, and I wish you all the success in the future. And if I could ever be of any help, I'm always happy to help people. Yeah. Does anyone have any questions about anything? I know I gave you a lot of information. Yes?
What were some of any of the setbacks or self-doubt that you might have experienced?
Oh, so that the well, I'll say is perceived setbacks. They happen all of the time, something that you think that's going to work out and necessarily doesn't. So I gave you an example of the experiment that I did that completely gave me the complete opposite results that I thought it was going to give me. And I thought I was at a standstill. Oh, shoot, now I'm going to have to completely change my project. And just with a little bit of thought, when I really thought about it, I was like, no, this does make sense. And was able to actually build on that and make actually a good set of data to go from. Even now, things that junior faculty members will face is figuring out funding, finding collaborators, finding mentors. All of those things are potential things that you might come across, but the key is that you stay persistent and resilient in that, and if something doesn't necessarily work the way that you thought it was supposed to work out, just take that as a learning opportunity and then reapproach it from another direction. Other questions? Sure.
How do you balance your work-life balance? How do you have work-life balance with clinical work and also research?
So that's a good question. I don't think that anyone has the perfect answer for that. Work-life balance and making sure that you as a whole are well so that you can function and perform and not get burnt out is really important, and it's a kind of an individual thing. There are going to be times in your career where you will work a lot, and it's just part of the nature of the beast that there's times when you really do have to focus to make sure that you're getting what you need done. But the key is just to make sure that you plan in time or plan in fun time away from work time, so that when you are in the spouse, like, okay, you know what, I have my boards coming up and I got to study for my step 3 exam. I know that that's coming up. I'm not really, I'm going to have to set aside this month of time where I'm not going to the movies. I'm going to be in the library and I'm going to study. But after that month time, I'm going to set aside time for me to go do X, Y, or Z. I'll take a day trip or a road trip or go to the movies or whatever to celebrate after I've finished my specific task. But it's all about scheduling, planning, and anticipating that there will be times when your workload will be a little bit higher than what you would like to be, but as long as you keep it balanced and you schedule in the fun time so you don't forget to do the self-help thing, and do the things that you know that you like to do. Some people run. Some people like to run. I like to paint. There are some people who told me that they like to knit. They'll set aside, okay, like every day or whatever, X number of time, I'm going to do so-and-so, and that's my, breakaway time. Make sure that again, that's part of like having that network of mentorship. And I had all different kinds of types of people there. So your mentoring team, that's people you have peer mentors, you have more senior mentors, but they help you to kind of keep your work-life balance as well, going out and doing things and not staying only, just work all the time, because you'll get burnt out. But coming up with a plan and scheduling things in is the best way to kind of help to make sure that things don't get out of kilter or off balance. Other questions? I'm happy to answer. Yeah.
Thank you for your talk. It was great. Did you ever have feelings of imposter syndrome? And if you did, how were you able to overcome that?
So you're meaning like when people are doing or perceive success and they, kind of
Yeah, exactly.
Yeah. Well, that's always something that people will have. I mean, for sure, there's times when, especially when it comes to your question about the burnout, at least myself, if I felt like I have not given myself enough time, break away, so that there's more balance in what's going on, you're more likely to kind of think about those kinds of things and let yourself, no, it's okay, I don't need to read that chapter now, or, oh, it's okay, I'll get to it later. And that's kind of like a self-fulfilling thing where you can end up self-sabotaging yourself when you know you really need to be sticking to a specific like study regimen or things like that. That's a pretty common thing that happens to people. I would say the best way, again, about navigating through that is that's why I talk so much about the prep and the planning and preparation and the mentorship. Because once you get outside of the box, or the guidelines of that box, your mentor will be like, well, did you study for that test? It's, you're getting about a week out, or I didn't get your homework assignment, what's going on? That was one way to help to keep you inside the box of the guidelines of what you want to do and keep yourself from self-sabotaging yourself. And then the plan is the other way of helping you, where you self-do that for yourself. You put together a calendar where you know what's due when or what your goals are, and then if you are constantly rechecking that, you will see when you're starting to do that, oh, I put that off like 2 weekends in a row. I need to get on top of that. But if you don't have a plan, you're not specific to that, that's how a problem like that will snowball, and people end up not having the focus, this lack of focus, and they make decisions not based off of how they're going to get to the target. They get driven off to other things that really aren't in alignment with their true self. Yes?
What's a typical week like in your job?
A typical week. So it depends on whether I'm on the stroke service as the attending or if I'm not on service. So if I'm on the service as a stroke attending right now, I'll arrive at the hospital around 7:30, 8 o'clock in the morning. I sit with the team in the workroom. There's usually probably maybe 8 members of the team. We'll listen to the resident tell me about the admissions from overnight as they tell the other residents about them, so that there's a handoff of care. We'll go through each of the individual patients, so pull up imaging. We do teaching in the morning. I try to do at least 15 to 20 minutes of dedicated teaching on a specific topic so that everyone is learning. Then we move on to the inpatient rounds. And then on inpatient rounds, we go to each individual patient's room. We'll do an exam on the patient, talk to the patient's family about what their test results were, what this means for them, how we're going to try to prevent them from having a stroke in the future, and then whatever tests are organized for the day. And then we continue that until usually around noon or 1, by the time we finish seeing the patients. On average, I would say we may have 25 to 30, 32 patients on the stroke service that we see and round on, depending on whether we have a lot of people in the north who will come down during the winter time, and so the service size is a little on the larger scale, whereas now when it's hot, most of the patients will go up north because they don't want to be down in Florida when it's 97 degrees, so the service size is a little bit slower. In the afternoon, we'd have a tendency to have the patients who are found with stroke symptoms, because usually people are eating with someone and they've found them, they dropped the fork and they've got the facial droop and things like that. So stroke alerts is what we call them. We'll come in at that time and we go down to the emergency room and see the patients, evaluate them, determine if they need to go to the angio suite to get the clot pulled out. I usually am there until around 5 o'clock and then have take-home call from the residents or the fellow who's on, if they have any questions about acute intervention cases or patients that are in the emergency room that they're not sure if they want to have the patient to go home or if the person needs to get admitted to the hospital. And I do that for about 7 days straight. And that's a typical work week for when I'm on the inpatient service. When I'm not on the inpatient service, then I have the first part of the week is based more administrative type work. So helping with clinic patient, outpatient clinic needs, helping to organize the clinic service and make sure that it's running more smoothly in conjunction with the committee, and then also working on research during that time, meeting with collaborators, I also participate in a stroke blog, so writing stroke blogs and things of that nature. And then at the end of the week, I see more outpatient clinic patients, so they see them from usually around 8 o'clock in the morning until around 5 o'clock at night, and then have a half day of clinic on one day out of the week. So that gives a lot of flexibility during the times when I'm not on service. But when on service, we're really, a busy service. It's one other thing or two things that I wanted to mention that I didn't mention before, so I'll mention it now. So you mentioned things, setbacks, pitfalls, things like that. Back to the planning. So anytime when you're wanting to go through your career and do extended periods of training like I did, that's a lot, right? There's always a concern, or people have concerns about, what am I going to do with all this student loan debt? How am I going to function with that? There are programs at the NIH that do help with student loan repayment, so I did participate in that while I was at NIH as a fellow, and was able to get a lot of my student loans paid off with the LRP program, so that's a good thing to know about, what was the other thing I wanted to tell you? The LRP was definitely, that was the main thing I wanted to make sure I did not remiss on telling you about that. Any other questions from anyone? If not, that's okay. My email address is on the web, so if you wanted to just email me a question you didn't want to ask in front of the audience, that's fine also. I reply to my emails, and again, I'm happy to help in any way. I want you to be successful in whatever it is that you want to do. Okay, thanks for having me.